Welcome to Roadmap to Residency Evidence-Based Applications. Hello everyone, I'm Abhiraz, and in this video we will be discussing in brief about different types of lung cancers. So the risk factors of lung cancer include cigarette smoking because of the presence of polycyclic aromatic hydrocarbons, radiation therapy, for example, in case of patients with Hodgkin's and breast cancer survivors, environmental exposures like asbestos and radon exposure. The diagnosis is generally we can see a pulmonary nodule or coincident lesion in chest X-ray, and we compare this with a prior chest X-ray if it is available, or we have to go for CT guided biopsy or bronchoscopy guided biopsy. So the lung cancers are generally divided into small cell and non-small cell lung cancer. The small cell lung cancer generally comprise of the total 15% of lung cancer. These are fast growing, go into early metastasis, and they are non-amenable to surgical resection. Generally occur in case of patients who are smokers, and it is treated with chemotherapy and have a poor prognosis. But the non-small cell lung cancer are the most common lung cancer, generally occur in 85% of individuals, can sometimes be resected, have better prognosis, and occurs in both smokers and non-smokers. So small cell lung cancer is a poorly differentiated has poorly differentiated small cells, which are classically present in male smokers. They are neuroendocrine tumor and they are centrally located. These tumors can generally show a paraneoplastic syndrome. For example, they can produce ACTH, which can go into Cushing syndrome, progressive obesity, and hyperglycemia. There can be production of SIADS, which can lead to hyponatremia. So the patients may present with confusion in the early stage. It can also produce antibodies. So antibodies against the presynaptic calcium channels in neurons can be there, which can block the release of acetylcholine. So the patient can come with symptoms of Lambert-Eaton syndrome, and the main symptom in this patient may only have is weakness. So it is very crucial to diagnose or to rule out small cell lung cancer in these sort of patients. So 65-year-old man presents to his primary care physician with complaints of worsening cough, hemoptysis, unintentional weight loss, and fatigue over the past few months. He also reports difficulty breathing and chest pain. Physical examination reveals decreased breath sounds on the right side of the chest, and the chest X-ray shows a large mass in the right lung with mediastinal lymphadenopathy. The biopsy of the mass reveals a small round blue cells with scant cytoplasm and finely granular chromatin. Which of the following is the most likely diagnosis? Adenocarcinoma, squamous cell carcinoma, large cell carcinoma, small cell lung cancer, or carcinoid tumor? So the clinical presentation of a 65-year-old man with worsening cough, hemoptysis, unintentional weight loss, fatigue, difficulty breathing, chest pain, and physical examination findings of decreased breath sounds on the right side of the chest, along with radiographic evidence of a large mass in the right lung with mediastinal lymphadenopathy, is highly suggestive of a small cell lung cancer, which is characterized by small round blue cells with scant cytoplasm and finely granular chromatin as seen on biopsy. Histologically, these cells show neuroendocrine differentiation. The small cell lung cancer is typically centrally located and often presents with extensive local invasion and early metastasis, as evidenced by mediastinal lymphadenopathy in this case. The clinical features include cough, hemoptysis, weight loss, fatigue, and respiratory symptoms due to local tumor growth and compression of adjacent structure, and it is strongly associated with cigarette smoking. Now, some of the non-small cell cancers are squamous cell carcinoma, adenocarcinoma, large cell carcinoma, bronchoalveolar carcinoma, and carcinoid tumor. So whenever we study about non-small cell lung cancer, so you need to be more focused on the histology of these sort of tumors, okay? Because these may be the only hint that will help you to diagnose these questions. And then comes the theory part. So the adenocarcinoma is generally peripheral in location, and it is the most common primary lung cancer. Most common type in people who do not smoke. So most common type of lung cancer in non-smoker is adenocarcinoma. It is most common in females than males, and some activating mutations include KRAS, EGFR, and ALK. So since it is not involving in smoking, non-smoking individual, non-smokers, so there should be some mutation involved. So the KRAS is the one that is very commonly asked. It can be associated with hypertrophic osteoarthropathy, that maybe the patient may have clogging. So the chest X-ray shows hazy infiltrate similar to pneumonia. The patient may have glandular pattern and often stains mucin positive. So here you can see this this, here, and here. These all are mucin, okay? Now, these all are mucin stain positive, and so you can say that this is a case of adenocarcinoma. Whereas in case of squamous cell carcinoma, it is generally central in origin, and so the patient may have a hilar mass, which may arise from bronchus, and the patient have a history of smoking, and there are keratin pulse that are present. So here you can see they had this and this. Now, this is a keratin pulse, which is present in case of squamous cell carcinoma, as a very, very distinctive feature of squamous cell carcinoma. Whenever we talk about large cell carcinoma, it is also generally peripheral in origin. The patient has a history of tobacco smoking, may produce beta HCG, so the patient may have gynecomastia or enlarged breast. And we can see some leomorphic giant cells. So here is one giant cell, here is one giant cell, here we can see one giant cell, okay? Now, these all, due to this presence of these giant cell, we call this large cell carcinoma. Where there is some rare type of tumor, which is called as the bronchial carcinoid tumor, which may be central or peripheral in origin, and it stains chromogranin A positive, and that information is asked in the examination. So, a 55-year-old man or woman presents to a primary care physician with complaints of persistent cough, shortness of breath, and unintentional weight loss over the past few months. She has a history of smoking 30 years but quit 5 years ago. Physical examination reveals decreased breath sounds on the left side of the chest. Chest X-ray shows a peripheral lung mass in the left upper lobe. Biopsy of the mass reveals glandular structures lined by coronary epithelial cells with mucin production. Now you know the diagnosis, that is adenocarcinoma of the lung. Thank you for watching. Keep studying hard.